Look at that.
Sorry about that.
No problem. And you want this one first, right?
Yeah, I think that was requested.
Yeah. How's everybody doing? We're going to call this meeting of Health and Human Services to order. Today we have three agency readouts. That is the West North Avenue Development Authority, Maryland Department of Health and Public Health Administration, the MDH Prevention and Health Promotion Administration. And at this moment, we're going to call up Ms. Naomi Camaro to read out for the MDH Prevention and Health Promotion Administration.
Thank you, Mr. Chair. My name is Naomi Camaro. I'm the budget analyst with DLS, presenting the fiscal 27 budget for FIPA, the Prevention and Health Promotion Administration. The budget for FIPA decreases by 6.7% in fiscal 27 to $508.3 million. On page 3, we begin discussion, of one of the performance measures that FIPA reports related to tobacco use programs. The exhibit on page 4 shows the percentage of adults by different demographic groups, as well as all adults who smoke cigarettes in each of the fiscal years between 2021 and 2025. This chart shows that as of fiscal 2025, tobacco usage among all adults has decreased to a level below the goal that FIPA has set. DLS has asked FIPA to comment on its plans to update its goals related to adult cigarette usage to reflect current trends and population health objectives. Next, we discuss tobacco usage rates among youth. So the exhibit on page 5 shows the usage of cigarettes and electronic smoking devices among middle school and high school students between fiscals 2018 and 2024. And while usage among these groups is declining, there's some progress to be made to meet the goals that the health department has set. Next, I want to briefly talk about a provision in the BRFA that would reduce the mandate for the amount of funding that needs to be in the budget annually for tobacco cessation programs. So currently, the governor is required to include $18.25 million for tobacco cessation programs. And there is a contingent reduction on the general fund appropriation fiscal 27 that would reduce that appropriation by $730,000, contingent on enactment of the provision that would reduce that mandate. However, this does not match, the language in the budget bill does not match the language in the BRFA because the language in the budget bill is contingent on a provision that would eliminate the mandate. And so DLS is recommending modifying the budget bill language to align with the provision in the BRFA as introduced. After accounting for the contingent reduction, the fiscal 27 allowance includes $18.4 million for tobacco prevention and cessation programs. And we've asked FIPA to clarify how it determined this new level of $17.52 million for mandate and explain the impact that this reduction would have on tobacco use reduction programs at the local level and statewide. We also recommend increasing the contingent general fund reduction by $850,000 to meet the proposed mandate of $17.52 million. The next section summarizes some of the grants that were determined to be at risk due to recent federal action. And we note that FIPA has not lost any funding to date due to resolved and ongoing litigation. But given the uncertainty of future funding, we've asked FIPA to comment on its efforts to monitor ongoing changes at the federal level and its communication with grantees. Next, I'm going to flip ahead to page 8, which has a pie chart showing the breakout of how the fiscal 27 budget is allocated across FIPA. So nearly half of the budget is allocated to the Maternal and Child Health Bureau, which includes funding for the Women, Infants, and Children program, which is budgeted at $163.6 million in fiscal 27. And then just over 20% of the budget is allocated to the Cancer and Chronic Disease Bureau, which includes the Tobacco Cessation Program funding, and a little more than 20% of the budget is also budgeted in the Infectious Disease Prevention and Health Services Bureau, which includes funding for MADAP, which is the Maryland AIDS Drug Assistance Program. On pages 9 and 10, we summarize the major changes between the current fiscal year and fiscal 2027 in FIPA. So again, the total budget is decreasing by $36.6 million. That's driven by the end of COVID-19 relief supplements to the ELC grant, which is a federal grant for infectious disease prevention. So there's $62.6 million fewer in the fiscal 27 budget compared to fiscal 26. This decrease is offset by increases in a few different areas, including for the WIC program, which is projected to increase as it has been in recent years. There's more information on that in the update section, which I'll touch on briefly in a minute. There's also an increase of $7.4 million in special funds for MADAP programs. So that's programs that support HIV prevention and treatment, because the department is trying to spend down elevated fund balance. Which leads me to the next section that kind of describes in more detail how that fund balance came about. So the MADAP program is supported by federal funding and special funds that come from pharmaceutical rebates. And the department has been both experiencing and projecting decreased revenue in recent years because revenue is tied to the infection rate, which is decreasing. At fiscal 24 close, the balance of MADAP was $1.1 million. And FIPA made several efforts to improve collection efforts, which ended up being quite effective. In fiscal 25, the revenue was $64.6 million, and the closing balance was $46.6 million. This is illustrated in the exhibit on page 12, which shows the legislative appropriation for each year, the amount of actuals spent from the program in each year, and the closing balance. And so FIPA has indicated that it is attempting to spend down that excess balance because revenue came in higher than anticipated. We've asked FIPA to comment on any other efforts that they've made to spend down the fund balance while ensuring there's still sustainable spending for MADAP programs based on service demand. For the section on the Budget Reconciliation and Financing Act, I've already talked about the proposed change to the Tobacco Cessation Program mandate. There's another provision that would expand the authorized uses of the Advanced Directive Program Fund and effectuate a fund swap that would reduce $1 million in general funds and replace it with special funds from the Advanced Directive Program Fund. With regard to personnel, which is summarized on pages 13 and 14, in fiscal 26, FIPA abolished 9 positions through the voluntary separation program. One of those positions was vacant. And the total number of regular positions in fiscal 27 decreases by 33, which is entirely due to transfers within MDH. As of December 31st, 2025, FIPA had 81.6 vacant positions, and 33 of those have been vacant for 1 year or more. This does not assume that any of the positions transferred into FIPA are vacant or were vacant. And so we've asked FIPA to specify how many of these transferred positions were vacant and to comment on its plans to fill or abolish the long-term vacant positions. Now moving on to the issues section, starting on page 15. This section really just describes the major changes to the federal guidance on immunization schedules. So the federal government, the CDC, released in January updated guidance that reduces the number of recommended vaccines for all children from 17 to 11 and changes the recommended amount of doses for the HPV vaccine from 3 to 1. Maryland, and one more change I want to point out is that CMS removed the requirement that states must report certain immunization-related data measures to the federal government. And so some of the measures that were removed were the childhood immunization status in states, immunizations for adolescents, and prenatal immunization status for people of all ages. States can still report this data, but because it's voluntary, there's a risk that the availability of national data may decrease in future years, which of course has implications for vaccine policies. The next section summarizes the immunization policies in Maryland. So Maryland and a few other states, in anticipation of some of these changes at the federal level, joined the Northeast Public Health Collaborative, which is a multi-state coalition established to set public health guidelines. The General Assembly also passed Chapter 738 last year, which requires healthcare payers to cover vaccines in accordance with the ACIP recommendations as of December 31st, 2024. And then lastly, there is proposed legislation this legislative session, SB 385 and HB 637, or the VAX Act, which would authorize the Maryland Secretary of Health to publish recommendations that are aligned with some of the nation's top health agencies, or not agencies, rather, coalitions, including the American Academy of Pediatrics, as well as consider the guidance from the Maryland Statewide Advisory Commission on Immunizations and federal agencies, including the CDC and the FDA. The bill would specify that in most situations, insurers must cover the cost of the vaccines that are included in the Secretary's guidance. The last issue of this analysis relates to the Pediatric Cancer Fund, which was established by Chapters 253 and 254 of 2022 and require MDH to distribute grants for pediatric cancer research, prevention, and treatment. Subsequent legislation altered the allowable uses of the fund to cover pediatric cancer research only and also established a commission to support the grant process. In fiscal 2023, the governor added $5 million to the budget for the fund, but the department has not yet expended any of the funds due to delays in appointing the commission. As of October 2025, the commission has been fully appointed, and FIPA indicated that it will soon hire a full-time program administrator to oversee the program. The fiscal 27 allowance includes $2.5 million for the grants. DLS has asked FIPA to comment on when it plans to release a request for proposals for the grants and when it will hire the program administrator. And we've also asked FIPA to discuss how the grants will be used on a one-time basis, as there's no clear ongoing revenue source, as well as the timing for distributing the grants. Lastly, I just want to note that on pages 19 and 20, there is a brief update on the WIC program. As I said earlier, enrollment has been rising and is projected to increase. We have asked FIPA to specify the fund source that was used last year to continue distributing benefits. The governor appropriated $10 million in emergency funding during the federal government shutdown in October. We've also asked them to clarify if that $10 million emergency appropriation was expended in fiscal 2026. Finally, DLS recommends amending the contingent language on the general fund appropriation related to the tobacco use cessation program mandate. And I can take any questions if there are any.
Senator Augustine.
Thank you, Mr. Chair. Just for my education, is there like a benchmark on vacancy that we seek to have? Because I just don't know.
Every agency is different. So we do budget, there's what we call budgeted turnover. So there's an amount in the budget that says at X% is what we've budgeted to account for any vacancies that might arise throughout the year. So when you look at that chart, for example, you can see what the agency's budgeted turnover is versus what the actual vacancy rate is, to give you a sense of this is more vacancies than we planned for in the budget.
Okay, so I appreciate that, but is there like a benchmark that we seek to, that we think is like best practice for that?
Yeah, I don't think that there's a uniform one across all agencies. All agencies are a little bit different. So that would be a good question for the health department if they have one for FIPA specifically, but it sometimes changes. So this was not the same amount that was budgeted last year that they were aiming for.
Okay, thank you.
Mm-hmm.
And Senator Augustine, one of the things that I try to pay attention to is the ones that's been vacant for over a year, you know, and I'll point that question out when they get there. And at this point, we like to call up MDH, Dr. Meg Sullivan. Oh, Madam Secretary.
Surprise!
It looks just like the health secretary.
I know, right?
Well, Chair McCray and members of the HHS Subcommittee, for the record, I am Dr. Mina Seshmani, Secretary of Health for the state of Maryland. The department thanks the governor, the Department of Budget and Management, and the budget committees for their support. And we thank the Department of Legislative Services for its insightful budget analysis of the Public Health Administration and the Prevention and Health Promotion Administration. I also want to acknowledge the recent report and recommendations published by the Commission on Public Health to continue advancing public health priorities across the state. The department looks forward to continuing to work with the Commission members and affiliated coalitions such as the Maryland Association of County Health Officers, MACHO, and Maryland Association of Counties, MACO, to advance the recommendations and protect the well-being of our communities. I'm pleased to be joined today by Deputy Secretary Dr. Meg Sullivan and members of the Public Health Services leadership team. And we stand ready to engage on matters and answer your questions concerning the Public Health Services Administration today. But before we do so, I'd like to highlight a few examples of how the governor's budget will help us deliver on our priorities and commitments in some key public health service areas. First, vaccines. As you know, vaccines remain one of the most powerful public health tools that we have to keep ourselves, our families, and our communities healthy and safe from disease. And so in this budget proposal, there's continued support for the first of its kind effort, the Maryland Vaccine Program, or MVP. Under this program, local health departments are providing life-saving immunizations free of charge to uninsured and underinsured adults throughout Maryland. Second, the budget also continues support for women's health and maternal health priorities, which continue to be a key focus as we implement legislative priorities through evidence-based programming and initiatives addressing both long-standing and emerging needs. Third, the budget continues support for public health infrastructure, including the Maryland Laboratories Administration, the Office of Preparedness and Response, and local public health departments, which play a critical role in tracking serious community threats like infectious diseases or contaminated water supplies. And fourth, the Public Health Services Administration is also home of the Office of Healthcare Quality, which is charged with licensing, inspecting, and regulating 1,624 licensed assisted living facilities, 220 nursing homes, and numerous providers across the state. So I look forward to this budget hearing and future ones where we can further discuss the investments that are playing a critical role in ensuring an adequate and safe healthcare system for Marylanders. So overall, thank you for providing me with an opportunity to highlight a few of the areas from the Public Health Services and then specifically from the Prevention and Health Promotion Administrations and the work that we do to continue to protect Marylanders. We look forward to working with you, members of the General Assembly, advocates, community members, as we pursue our collective vision of a high-quality healthcare system that produces the best possible health for Marylanders across their lifespan. So with that, I will turn it over to Dr. Meg Sullivan and team to address the specific budget questions. Thank you.
Wonderful. Thank you so much, Secretary Seshamani, and good afternoon, Chair McCray and members of the subcommittee. I just want to echo our support and thanks to the Governor, the Department of Budget and Management, and the Budget Committee for their support. And again, thanking our Department of Legislative Services analysts for an incredibly thoughtful budget analysis. I will just briefly run through, so you have our written testimony for the record. I will briefly run through some of the responses that were highlighted during DLS's testimony. First and foremost, would just like to concur with the DLS recommendation that the budget submission complies with the language and appreciate all of the support. We were first asked to comment on its plans to update our goals related to adult cigarette usage to reflect current trends in population health objectives. And we'll note that the Behavioral Risk Factor Surveillance System, or BRFIS, is the only ongoing comprehensive state-level surveillance system that provides representative adult tobacco use data for Maryland. Prior year data is typically finalized by the end of the subsequent calendar year, which means that calendar year 2024 data was therefore not available until after the FY 2027 MFR Managing for Results submission was finalized. So FIPO will use the 2024 BRFIS data to update the adult tobacco use goals in the FY 28 MFR template. We also just wanted to concur with the recommendation that DLS made modifying the BRFA language to align the provision in the BRFA as introduced by making the general fund reduction to the tobacco cessation funding mandate contingent on legislation reducing the funding mandate. Thank you. We were asked to clarify how this new determined mandated level of $17.52 million was determined and explain the impact that this reduction will have on tobacco use reduction programs locally and statewide. I'll stop there. We do not anticipate any negative impact on tobacco use reduction programs based on this new updated level. The Tobacco Control Program has accomplished significant decreases in tobacco use and is estimated that the $17.52 million will be sufficient to maintain its effectiveness and continue to decrease tobacco use in Maryland. Turning to federal funding, given the uncertainty of future funding that was commented on, we were asked to comment on our efforts to monitor ongoing changes at the federal level and communicate with grantees. We'll say that the federal FY26 Consolidated Appropriations Bill enacted February 3rd, 2026 does have largely level funding for the major HHS grant programs at the federal level. However, knowing some ongoing uncertainty, we are continuing to closely monitor federal grant funding opportunities and any proposed changes to existing grant programs that would affect FIPA's operations. And of course, we'll continue to prioritize timely communication with our grantees. Next, we are asked to comment on other efforts to spend down fund balance while ensuring sustainable spending on our MADAP programs based on service demand and available revenue. We'll say recent federal legislative actions and inactions affecting the Affordable Care Act insurance premium subsidies, resulting in an estimated 17% increase in premium costs. And therefore, the MADAP expenditures are increasing significantly as compared to FY25, as MADAP has expanded its insurance assistance to ensure no lapse in client care. MADAP will allocate the $46 million in existing fund balances over a 5-year period as both one-time and multi-year investments to improve program data systems, including a new integrated client management data system and patient portal, enhancements to HIV and sexually transmitted infection prevention programming, including integrating adolescent and young adult HIV PrEP and post-exposure prophylaxis, and continued sustainability of MADAP services. Next, turning to staffing, we were asked to specify how many of transferred positions are vacant, as well as comment on plans to fill or abolish its long-term vacant positions. So as noted, there are 508 merit full-time equivalent budgeted in the FIPA programs in FY27 allowance, which is 33 FTEs fewer than the 541 FTEs budgeted in FY25 working appropriations. This decrease of 33 from FY26 to FY27 reflects the realignment of 37 positions from FIPA to other programs and realignment of 4 positions to FIPA. Of the 37 positions realigned out of FIPA, 22 are filled and 15 are vacant as of January 31st, 2026. We have continued to prioritize filling our vacant positions, focusing currently on mission critical positions and then other positions as well for the hiring freeze exemption process. We expect to fill all vacant positions after the lifting of the statewide hiring freeze. Just 2 more. We are asked to comment on when our plans are to release a request for the Maryland Pediatric Cancer Fund proposals and when we will hire a program administrator. And considering the grant program is supported with a fund balance and does not have an ongoing revenue source, we should discuss how the grants will be used on a one-time purpose and timing for distributing the grants. So first, we'll say that FIPA expects to release the RFP in November of 2026. And based on the recommendations of the commission, funds will then be distributed for a 24-month award beginning in March 2027. The commission advises that these one-time awards will have significant impact on time-limited specific research objectives or be leveraged for specific outcomes within larger research initiatives. And currently, we plan to hire the program administrator position when the hiring freeze is ended. And last, we are asked to specify the fund source used to continue distributing WIC benefits during the federal shutdown and whether the $10 million emergency appropriations was expended in FY26. So the WIC program did remain open and operational during the federal shutdown by utilizing the prior federal fiscal year funding as well as as allowed by the federal regulations, as well as federal funding provided by the USDA during the shutdown. The $10 million in emergency grant fundings was made available not for WIC operations, but rather to purchase and distribute additional food for food banks, local pantries, school pantries, and mobile distribution programs through the Maryland Department of Human Services. So that concludes our written testimony, and we are now ready to answer any questions.
Senator Augustine.
Thank you, Mr. Chair. Thank you for the presentation, and it's good to see you, all of you, including you, Madam Secretary. So there are, as it relates to sort of like data, a lot of times and you all will send your data up to the federal level, like definitely on the BRFS for sure, where obviously it's aggregated, we're able to use it there. Are they still, that's real quick, are they still taking our data and across the board?
The reason I think I'm pausing is because when you say across the board, I think it is fair to say that there definitely have been changes and disruptions to the way that federal or the communication between state data and federal data, both in terms of what is being required, what is being accepted, what is being processed, and the timelines by which we're receiving it down. For the BRFS data, for example, we are still receiving that, but we are, particularly for the FY25 data, encountering a few changes in the process or potentially delays, and it's something we're watching closely.
Okay, I guess really where I was, I figured as much. That's just more validation of that. I guess what I'm curious about, and I'm concerned that we have very important public health data that we have. I'm curious as to whether or not we depend on any federal sort of repositories where we may, and do we have any contingencies that we're able to keep our data whole, and do we have financial, or do we have the money to do that as a problem? I mean, this is serious. So could you just respond to that for me?
Yeah, I mean, I will say, and then I don't know if others want to add, but this is a conversation that we are having across the board, whether it's funding, whether it's program operations, but certainly about data. I think it is fair to say that there has been a very strong and important relationship and reliance on federal support for data. Yeah. That is, we have seen interruptions in. We are identifying those and have started identifying where are those critical places where we need to continue to have that services and contingency plans for where those interruptions may be. Again, there's places where the data is still happening well. There's places where we're starting to see interruptions. We are looking at how we can use our own data sources that are existing. Can we build them up a little bit? Can we collaborate with other states? These are conversations we're having as part of the Northeast Public Health Collaborative, for example. But I think to your point too, we also know that we are in a resource-constrained environment, and so some of these data systems do take time and money, and so we're really trying to evaluate where the most critical ones are and what we prioritize.
Okay, and Mr. Chair, forgive me, I'm just trying to get to, but that is not necessarily contemplated at this moment in the budget allocation that you have. That's what I'm trying to really get a sense of.
Correct. There is
It's
not
not contemplated.
there is not a specific request for that right now.
Okay, thank you, thank you.
The first one with the long-term vacancies, can you just connect with Ms. Camaro to get a better understanding, like what is going to take place throughout the year, and when do you feel as though those positions will be filled would be helpful, especially the ones, like I said, that's been there for 1 year longer. In reference to the Pediatric Cancer Fund, you spoke to November 2026 when the RFP was going out. That's the third quarter of this year. Like, help me understand, like, the delay.
Yeah, and I'll turn to Director DiMartino as well. I know that there was initial delay in terms of creating regulations as well as standing up the commission, which did take time. I also know as we look at the RFP, we are looking at eligible entities, and there's some evolving processes about who is eligible that I think we're waiting to be finalized, but you want to say more?
No, actually, I think you covered it. The greatest delay really was seating the commission, and then we are working closely with the commission to develop the parameters for the RFP.
And the hiring is taking place?
For that position, that hiring has not taken place.
Do you have a date on when it will take place?
I do not.
I think that's something we're looking at in the context of the hiring freeze. What I can say is that exact hiring is not holding up the release, though, of these funds. We are able to do that in the absence of the hiring. But I will say, and personally, we share the urgency and are working to get this funding out as quickly as possible.
If you could just share with Ms. Camaro to affirmative date when you all have, or a goal that you all have as an agency in reference to the hiring would be helpful. That's the person that leads this respective space. And then in reference to like accountability measures, like if you guys can kind of share with the committee what metrics you're using just for measurable outcomes in 6 months, what you expect from that standpoint. Can you speak to some of the programs in reference to the tobacco money that would be reduced? Because I didn't see that within here.
Yeah, I think this is something that we looked at closely, and obviously, anytime there's a reduction, we analyze what impact it would have on services, right, to individuals and to the community. I think we are fortunate to have had an investment in funding and be able to stand up a lot of great programs, which I'll turn to Director DiMartino to talk about. We never want to really see a reduction, but also understanding with the level of reduction in some of the existing work we've done, particularly given the progress we've made. I think we feel confident that we can absorb it. But do you want to say more on that?
Sure. I think it's always a challenge when we're facing fund reductions. We are also in a moment where we have the privilege of getting closer to our goals and less adult tobacco use. And so we are focused in on where some of those disparities might be and specific populations. So there's significant work happening that is much more targeted, which is a different approach, where we're moving away from some of the larger blanket activity and really focusing in on some of those populations where we have not seen the same level of movement.
Only because you use the choice of words, no negative impact. Is that like data that you're like? Is this something? How are you citing where you feel that strong that it'll be no negative impact with the budget reduction?
Yeah, and I think it's hard to say anything with certainty, right? But I think we are looking at a couple of things. I think first is what the actual data shows in terms of prevalence of smoking, both or tobacco use more broadly across the state, and then at specific populations. And I think that's what Director DiMartino was looking at, as well as some of our programs, what they've already been able to accomplish, and then what they're looking to do going forward, and what those resources would be.
If you do see a negative impact, are there any triggers in place so that you guys are aware of it, whether it's adult use, youth use, or things of that nature?
Yeah, I think that is something we're watching closely. I know we talked about some of this data and consistently getting updated data, both at the federal level as well as data that we're looking, that we collect in with our community partners. Whether it is, to your point, we are very cognizant of youth prevalence, increased marketing, some of those risk factors among other populations, and I think absolutely would raise a flag if we started to see those numbers go in the wrong direction.
Yeah. Last question in reference to the vaccines. I hear about it very broadly, so I saw it was 17 things of that nature. Like, what's the three most that you all are very concerned about from the actions that's coming through from the federal government?
I think you should answer this, pediatrician.
My first question was just three, but so I think first and foremost is confusion. We have heard kind of widespread confusion, both from patients and from families, as well as from providers, about what is actually being recommended. And this is something that I think we are working very hard to try and be clear about at the state level, but understand that there is a lot of confusion out there. The second one is access. And understanding the role or the interplay that traditionally for the federal recommendations have played in terms of providing access to vaccines, whether it is through insurance coverage, whether it is through the Vaccines for Children's program or for other reasons. And so watching that very closely. And then I think the third one is about the process. And I think we have really been committed to and relied on a data-driven, transparent process. And when we see an interruption in that, that has really caused a lot of challenges. And again, something that we're trying to mitigate here in Maryland.
Okay. And just to reiterate some of the requests, just the long-term vacancies, the hiring date, and just like what is some of the goals and the operational plan for 6 months or things of that nature when them grants get handed out. Ms. Kamara, I just want to thank you again for the thoughtful. Senator Zucker.
I want to thank Ms. Kamara, too, for the thoughtful. You read my mind, Mr. Chairman. In terms of the vaccines, what we heard, and you all know this, we heard that now some of the data that is provided to the federal government is now voluntary. What is your, I mean, this is more of a national question more than a Maryland question, but I'm sure we're all one big union, right? So it's going to impact us all. What is the lack of that data that the federal government's collecting? What is your sense in terms of long-term impact?
Want me to take, or you want
You want to start? No, finish.
I can start. So I think what overall with data, it's hard to improve what you can't measure. And so I think in general, having data is very important for all of us as we are tracking trends, as we are tracking prevalence. I think also viruses do not respect state borders, right? And so this is a problem that would then extend beyond our state. And that is why, as Dr. Sullivan mentioned, we have joined with the Northeast Public Health Collaborative. We have joined the GovAct Public Health Alliance, because I think there is an understanding of a need to have that cooperation across state lines so that we can see where there are areas for us to be able to further collate data. Also, where there are opportunities to some of what Dr. Sullivan mentioned in terms of process, I would add on there supply chain and how you actually go about procuring vaccines to then get the shot in the arm. And this is where, again, having partnerships across states can end up being very helpful. So I think, what we are doing here in Maryland is really working with other states across the country to make sure that we continue to have a strong fabric of public health to support against vaccine preventable disease.
Yeah, and I think I will just add, first as a pediatrician, I look at that data, right, as I think about the patients that I serve. I've worked at the local health department level where I know how we use that data to inform how we can improve. And will say, since I've been in this role, I mean, it is barely a day that goes by that I'm not talking with the team about, right, what are we seeing in terms of flu vaccine uptake this season and what do we need to do differently? What is our school vaccination rates? We really do use that data. And so the idea of losing it is very concerning to us.
Thank you, Mr. Chair, for the indulgence, but Senator Zucker raised something that was on my mind, so I will bring it up, which is that I do believe that the state of Illinois joined WHO, actually, And I raised it with you all, and it seems that you guys have a bit of a different approach, but it was kind of a short answer. Would you just share with me sort of why that may or may not be the right approach as far as Maryland joining WHO?
Yeah, absolutely. You know, I think this is where we have the strength of our partnerships, both with the Northeast Public Health Collaborative and GovAct, to be thinking together about how we are engaging with another global organization such as the WHO. So those are ongoing conversations that all of us are having. To Senator Zucker's point of knowing where are there gaps and how best to engage to be able to address them.
Okay, so Illinois is not a part of a pact or anything like that? That's why they would have joined the organization?
I can't speak to why Illinois made a decision that they did, but I know for us, we are looking in partnership with the other states that we have these partnerships with to figure out how we can best go about getting the data that we need.
All right, thank you.
Yes, sir. And Madam Secretary, at this time, we're going to bring up public testimony, if that's okay.
Yeah. Thank you again.
Yes, ma'am. Colleagues, at this time, we'll bring up Johns Hopkins and the University of Maryland.
Senator McCray, it's great to see you and the rest of you in the committee. And I'm sure our friends are here for the same reason we are, which is to thank this committee specifically, the legislature generally, for the long-term sustained support of the Cigarette Restitution Fund investment in biomedical research at the 2 academic cancer centers in the state. These funds have made a huge difference in recruiting talent to the state, enriching and augmenting the biomedical research infrastructure, commercial and academic in the state, and paying off in terms of less cancer mortality here in Maryland. And we're here just to thank you very much for your continued support. Let me turn this over to my colleague, Otis Brawley.
I'll be very brief. I'm Otis Brawley, a medical oncologist and epidemiologist in the Hopkins School of Medicine and Hopkins School of Public Health, and Associate Director of the Cancer Center for Community Outreach, and looking at what's going on in terms of cancer in all of Maryland. I want to say thank you because your money from the Cigarette Restitution Fund has been well used to stimulate research, to help us to understand a little bit more of what's going on within Maryland. By the way, discussing the data question earlier, we need cancer data in order to be able to figure out if we are improving and if we are getting better, and to figure out where in the state we have problems and where in the state we're doing well, learn what we're doing in those areas that we're doing well so we can translate them elsewhere. So thank you very much. And I'll pass off to our colleagues at the University of Maryland.
Thank you, Dr. Brawley. Good afternoon, everyone. Honorable McCray and members of the committee. I'm Taufik Owenigoko, the director for the Greenbound Cancer Center at the University of Maryland. It's a great honor to be speaking with you today and to thank you again, as already expressed, for your continued support through the Cigarette Restitution Fund. Privileged to lead our center, where the consistent 20+ years of support from the state of Maryland through the CRF has really positioned us to be able to impact the health and well-being of residents of our state. We want to specifically thank the committee, the General Assembly, the Madam Secretary, and Governor Westmore for the continuing support of the 2 leading academic cancer centers in the state. Greenbound Cancer Center remains an essential resource for the citizens of the state, and the 25-year history of CRF has enabled us to build the infrastructure, recruit outstanding physicians and researchers, to be able to name ourselves as one of the leading cancer research and treatment centers in the country. This support has catalyzed federal cancer research funding from $19.4 million when we were first designated to now an average of $100 million in federal research funding coming to the state through all of our members. In addition, the CRF enables us to train the next generation of cancer scientists, starting with students from schools in our West Baltimore neighborhood. We've provided cancer screening for tens of thousands of underinsured and uninsured citizens in Baltimore, saving many lives. And in that context alone, more than 40,000 people have been screened in the city of Baltimore alone. There are many ways to measure the impact of CRF investment on the citizens of Maryland, but I will highlight just a few and will turn this over to you as our record of testimony. The strategic investment of CRF has improved our status from being the worst in the nation to the best 12 in the nation as of 2021. There are more than 120,000 Marylanders who are cancer survivors today due to the investment of CRF funds in our institution and people. On behalf of those survivors who are your relatives, your neighbors, co-workers, colleagues, and your constituents, please accept our thanks and share our pride in the accomplishment of CRF. Thank you.
Senator Zucker. Usually you give them all types of shout outs.
Senator McCray, thank you for recognizing me. I join Chair McCray and Senator Augustine, and no, really thank you for your efforts. I think, Mr. Chairman, didn't we go on a site visit recently as well, just to see the state's investment in action? As we're investing money in you, you're investing in Marylanders, so thank you.
And I just want to thank both institutions. It's been fun to be able to visit both of you all, just be able to learn more about what you all do. I think they've had us the last 2 or 3 years from that standpoint, but it's been a well-learned experience. I just want to say thank you again. Colleagues, at this time, we still do have other public testimony. So at this time, we'll bring up Ms. Megan Peters and Skylar Ross. Oh, Megan's not here. And Skylar, you can start whenever you're ready. What grade are you in?
6th grade.
Oh, I love it.
Good afternoon, Chair and members of the committee. My name is Skylar Ross, and I'm a 6th grade student living with type 1 diabetes. I am here with the Diabetes Patient Advocacy Coalition and want to thank the department for its work on diabetes prevention and treatment. Every day, I make countless health decisions for my type 1 diabetes. I count carbohydrates, check my blood sugar, adjust insulin, and plan ahead so I can participate in school, sports, and activities with my friends. Diabetes does not take the day off. It is something I manage 24 hours a day. Because of advances in diabetes technology like continuous glucose monitors that let me see my blood sugar in real time and insulin pumps that automate insulin delivery throughout the day, I am able to make safer and faster decisions about my type 1 diabetes. Those tools, along with education and support for families, make it possible for children like me to live full and active lives. Programs that support prevention and health education make a real difference for families managing type 1 diabetes. They help kids stay healthy, active, and focused on learning at school instead of worrying about their health. Please approve Public Health Administration's budget so they can continue to support families with diabetes across our state. Thank you.
Senator Augustine.
Well, I would ask a question, wouldn't you? That's just a beautiful presentation, Tyler. Where are you from?
Maryland.
Which part of Maryland?
Montgomery County, Silver Spring.
Okay, wonderful, wonderful. And your advocacy, like what? I'm sorry, Mr. Chair. This is such beautiful advocacy on your part. How did you come to become an advocate like this for such an important topic?
While living with type 1 diabetes, I think it's important to advocate for what you believe is right. And through DPAC and going to Capitol Hill, I found like a lot of joy in doing so.
I'm very, very proud of you, and thank you so much for your testimony. Thank you.
Thank you.
Yep. Scholar, I just want to say, just thank you for your leadership. Thank you for your courage. And as my colleague stated, and on behalf of all of us, your advocacy, knowing that you're not doing it just for yourself, but doing it for all young people, as you stated it within your testimony across the state of Maryland. I continue to hope for great things from you. So I hope this isn't your last time in the people's house, but more importantly, each and every day, continue to walk into your greatness.
Thank you.
Colleagues, at this time, I am going to say thank you to Ms. Camaro for your thoughtful analysis and being able to help us see the picture a lot better. And Madam Secretary, I look forward to seeing you. Please don't hide in the back or the middle. But look forward to seeing you, and just thank you again, Dr. Sullivan, also for the work that you all did. Oh, please. Laura.
Thank you so much, Senator McCray. My name is Laura Hale. I'm with the American Heart Association. We have one concern with the budget, and that is around the additional cuts to the tobacco control program. We really appreciate all the amazing work that the health department has done in addressing tobacco control in the state and has made huge strides forward. One of the things that has been raised this year out of work done is the issue around electronic smoking devices. And one of the pieces from that is that we're seeing that the high school tobacco use rate is now higher than the adult rate in the state of tobacco use. So that's now up to 15.9%. Additionally, one of the bills that's been put forward this year has looked at enforcement concerns around our electronic smoking device retailers. And part of what the funding that has been collected for the state within the health department works to do enforcement. And so those additional funds that are being cut, we're really concerned on what that's going to mean for the continual enforcement needs. And part of what has been raised by the Alcohol and Tobacco and Cannabis Commission is a concern about the collection of the electronic smoking device tax, that's not being collected properly from all retailers. And without the partnership of proper enforcement, we are concerned on what that could mean for tax collection as well as the youth use rate in the state. And so we would ask that the funding not continue to be cut from the program, as they've been doing great enforcement work and need to continue with that. Thank you.
Thank you. Have you reached out to the comptroller in reference to the tax?
I have not directly, but I've been talking with Alcohol and Tobacco and Cannabis Commission on this.
Okay. Can you loop us into the conversation? Thank you. Colleagues, seeing that that was the last witness, we'll go to our next agency report, and that will be from Ms. Camaro again in reference to the Department of Health's Public Health Administration.
Thank you, Mr. Chair. So again, my name is Naomi Camaro. I'm a budget analyst with DLS, and now I will be presenting the fiscal 27 budget for the Public Health Administration. The budget for PHA decreases in fiscal 27 by 13.4% to $276.3 million. On page 2, we've summarized, again, some of the changes, some of the federal grants that were thought to be at risk due to recent federal action. Public Health Administration has not lost any federal funding from these sources to date due to the grants continuing under a preliminary injunction that was issued last May. There are 2 proposed deficiency appropriations in the fiscal 27 budget for fiscal 26 that would result in the PHA budget being reduced by $1.1 million in federal funding in fiscal 26. The pie chart on page 3 shows the spending by purpose in the Public Health Administration. The largest share of the budget is allocated to local health department funding. This includes prior year COLAs and the formula funding that is applied each year. Pages 4 and 5 summarize the major changes in the budget between the current year and fiscal 27. The entire budget decreases by $42.7 million in fiscal '27, which is really driven by the end of one-time expenditures related to COVID-19 response efforts that were incurred in fiscal '26 that were not eligible for FEMA reimbursement. The next section summarizes the Budget Reconciliation and Financing Act. The budget bill in fiscal '27 includes a $2 million reduction in general funds contingent on a provision that would authorize the transfer of $2 million in special funds from the balance of the State Board of Physicians Fund. This funding would support the Maryland Loan Assistance Repayment Program for physicians and physician assistants, which provides loan assistance to physicians and physician assistants who work in medically underserved areas. There's another provision in the BRFA that authorizes the transfer of $10 million in special funds from the MLARP for nurses and nursing support staff fund. However, DBM has indicated that this provision was written incorrectly. It should instead say that the transfer will come from the Nurse Support Program Assistance Fund, which lives in the Maryland Higher Education Commission. DBM will submit a BRFA amendment to correct that language. The next section relates to personnel. There are 14 more regular positions in the fiscal '27 budget than the fiscal '26. These are due to, again, transferred positions from other places in the Department of Health, which are listed out in that first bullet, in the second bullet on page 6. The first bullet points out some of the changes in fiscal '26 due to the voluntary separation program. There were 21 positions abolished in PHA. 12 of these were vacant at the time of abolition. There is, as of December 31st, 2025, there were 82.5 vacant positions in the Public Health Administration, which is about 31 more vacant positions than were budgeted for turnover. And more than half of those are in the Office of the Deputy Secretary for Public Health. The next section covers the key observations. The first relates to the Commission on Public Health, which was established by Chapter 385 of 2023. This section summarizes some of the work that the Commission undertook to assess our state's public health infrastructure and systems and make recommendations to improve foundational health services that the state provides. So the Commission worked for 2 years assessing the state of our public health system, making recommendations that were split up into 5 different categories that are summarized on page 10, including strengthening the public health infrastructure, modernizing communication data and IT tools and systems, leveraging and formalizing partnerships with different agencies, academic institutions, nonprofits, healthcare organizations in the private sector, increasing public health education and improving primary care access, as well as improving and expanding the public health workforce. The final part of this section describes some of the efforts that MDH is taking to implement these recommendations. And the Commission is working through June of 2026 to try and advance some of their recommendations as well. MDH has noted that there is potential to leverage new and existing federal funding, including through the Public Health Infrastructure Grant and the Rural Health Transformation Grant, to implement some of these recommendations. The next section relates to local health department funding and match requirements. So typically, local health department funding has been budgeted as grant funding that includes a formula funding for each jurisdiction, as well as salary adjustment payments for any state employees that work at local health departments. Each local health department has a different balance of state and local employees. And the larger health departments tend to have a greater share of local employees. In the fiscal 2026 budget bill, there was language requiring the Department of Health to budget these 2 buckets separately. So one budget for the formula funding, one budget for the salary-related funding to better track growth in the formula year over year. And so they did this. The fiscal '27 budget shows those two purposes budgeted separately. And so the Department of Legislative Services recommends the release of those restricted funds and will process a letter to this effect if no objections are raised by the committees. In fiscal 27, there is $83.1 million budgeted for the formula portion of the local health department funding. And the graph on page 13 shows how this allocation is split up between each jurisdiction. In this observation, DLS notes that while DBM says that there has been growth in fiscal 27 from a base of $80 million to $83.1 million, the total appropriation for local health departments, which is the formula funding plus any funding for prior year COLAs for any state employees, is level funded between fiscal 26 and fiscal 27. Because there was growth in the formula part of the budget, then that means to maintain level funding, there had to have been a reduction in the prior year COLAs. There are no fiscal 27 COLAs in the CPHS, the Core Public Health Services budget, yet. Those are budgeted, as usual, centrally in DBM, and they will realign that funding through budget amendment later in the year. We have asked MDH to update the committees on the amounts that will be allocated to local health departments to fund the fiscal 27 COLAs, how they will be allocated across each county, and when the local health departments will be notified of their allocation. We've also asked DBM to clarify when the fiscal 27 COLAs will be realigned into the CPHS budget. So as I mentioned before, some of the larger counties in the state tend to have a fewer number of state employees. However, there are 4 counties that do have at least one state employee, the chief health officer, but none of these counties received any funding for salaries in fiscal 27. And so we've asked MDH and DBM to comment on why there is no prior year salary funding budgeted for those counties despite having state staff members on their employment roll. The next section relates to local match requirement. Local governments are required to match a certain percentage of the amount they receive in core public health services funding each year. But when the appropriation for CPHS grows significantly, that means that the amount required, that they are required to match also grows. And so the department last year said that it intended on amending the regulations that govern the match requirements to put a cap on it. The fiscal 26 budget included language that restricted funding until the department submitted those amended regulations, which they did in January of this year. So DLS also recommends restricting those funds, releasing those funds that were restricted, and will process a letter to this effect if no objections are raised by the committees. Finally, DLS recommends concurring with the governor's allowance, and I can take any questions that you have.
See no questions, colleagues. Madam Secretary, just if you could hold for 1 second. There was one from the University of Maryland that didn't make it up with it, but if you could please come up at the mic this time.
Good afternoon, and thank you, Chair McCray. Thank you, Senator. Good to see you. My name is Nat Richardson. I'm the president of Capital Region Medical Center. That's a facility under the University of Maryland Medical System, and I really want to thank you all for your support of a grant that was administered in Prince George's County about 9 years ago. And the grant was administered to help transform care and to take care of specific issues in Prince George's County. When you think about cardiovascular disease, that's the #1 disease in the county. When you think about cancer care, specifically prostate cancer and breast cancer, that was an issue in the county. Many of our moms, for instance, 80% of our mothers in the county, the pregnant mothers, have at least 3 comorbid conditions. They're high-risk mothers, and we needed to address that. We needed to address vascular care in the county. We had a lot of amputations in the county. And there were many other conditions in the county that we sought out to address. And this grant has been the forefront in helping us to do that, creating or recruiting specialists to come to the medical center, like neurosurgeons, our vascular surgeons, our neonatal care, ICU physicians. We have been able to recruit a lot of MFMs, which are maternal fetal medicine physicians that can take care of moms and sick babies and not have to go to another facility if the baby is delivered and need sick care. We're the only level 3 NICU in the county. As you're aware, we're a trauma facility in that county. And we've been able to take this organization from just a critical care trauma and safety net hospital to a major comprehensive medical center, offering all of the various services that are needed in the county. If you take 5 years ago, for instance, we were delivering about 800 to 900 babies. We've doubled the number of babies that we have delivered. Cardiovascular care, open heart surgery has increased by 600%. We have been able to provide a lot of orthopedic specialty services in the county. And all of these are things that this county has needed, and this grant has been tremendously supportive in enabling us to provide that with specialists, not just from the physician standpoint, but nursing specialists and various other support team members to provide these services across the county. We want to continue that work. We know that we have to continue to do more in a county that has lagged behind in various health conditions when you compare it not only to the state of Maryland, but across the nation. I'll stop there and answer any questions that the committee may have.
Senator Augustine.
Thank you, Mr. Chair. Nat, it's really good to see you, obviously, and I'm grateful for the things that you all do. Is the grant in this year's budget? Is it ongoing?
Yes, sir, it is in this year's budget. It was a 10-year grant that started in 2017, so we're in year 9 of that grant, and there's one more year.
Okay, and you've made, I would imagine that this year, there's still more work to do, and so with this year, keeping and making sure that we continue to have this would be important to progress in Prince George's County?
Absolutely, and of course, you know, we're always looking for ways to expand upon what we're doing, but what I shared with the team is that I don't want just buildings. I want to make sure that those buildings have the services that are needed within the communities that need our service.
Thank you for your testimony. Thank you. Thank you, Mr. Chair.
And thank you. Colleagues, at this time, we're going to move back to the Public Health Administration, and we'll ask for Madam Secretary.
Okay. So first, thank you again, and good afternoon, members of the subcommittee. Again, for the record, my name is Dr. Meg Sullivan, and I serve as the Deputy Secretary for Public Health Services, which includes both VIPA and Public Health Administration, the other programs in Public Health Administration we'll be talking about today. I want to again thank the governor, the Department of Budget and Management, and the Budget Committee for their support, and again thank the Department of Legislative Services for its insightful budget analysis. We submitted our written testimony. We only have a couple of brief things to go over very quickly here, and then we'll be available to answer questions. We'll first just say for the 2 items where DLS has read and approved our submitted reports and recommended the release of funds, we concur with those recommendations and thank DLS for the support. And then just 2 questions that we were asked to comment on. First, to update the committee on the amounts that will be allocated to local health departments to fund COLAs in fiscal year 26 and 27. How the funds will be allocated by county and when local health departments will be notified. So for fiscal year 26, $3,657,975 is allocated to local health departments to fund COLAs in increments. The local health officers were provided this information on February 5th, 2026, broken down by county. And the allocations will be dispersed to the local health departments in February of 2026. Funding for fiscal year 27 COLAs and increments will be added to counties based on the number of employed state personnel. The total of amount and allocation has not yet been determined by DBM. And then finally, we were asked to comment on why there is no salary funding budgeted for the 4 jurisdictions for which the local health officer is a state employee, but the rest are county employees in fiscal year 27, despite employing at least 1 state staff member. And just we'll say local health department funding in fiscal year 27 was rebased to comply with the core funding formula requirement and the new stipulation that requires core funding and salary adjustments to be budgeted separately. So once the fiscal year 27 COLA is allocated, all counties with state staff will receive additional salary funding based on the number of their personnel. And that concludes our written testimony, and we stand ready to answer any questions.
Dr. Sullivan, just thank you for the testimony. Just a very quick question and just get a very quick response. This is aligned with MACO. I know that we had some issues with the local health department's funding formulas, but MACO had reached out over the interim and said y'all were aligned. I just want to make sure that
Yes,
alignment still exists.
and we work very closely with them.
Yes, ma'am. Thank you. Seeing no further questions, colleagues, we'll have our last agency report out. And I always thank you, and you're about to leave. Just thank you again, Ms. Camaro, and thank you again, Dr. Sullivan. West North Avenue Development Authority, and this is going to be by Ms. Elizabeth Waybo. Oh, you are so right. It was. We had, I apologize, 2 public testimony, 2 from AFSCME, Jenny Reese and Anissa Pierce-Sessmans. Thank you for that catch.
Good afternoon, Mr. Chair and the committee. My name is Anissa Pierce-Sessmans. I serve as an Executive Vice President with AFSCME Maryland Council 3. I recently retired from the Worcester County Health Department where I had 15 years of service. Our local health department and our public employees provide a variety of public health services in our communities, including behavioral health services, vaccinations for the community, nursing services, medical transportation for clients that need to get to their health appointments, and much, much more. However, recent funding cuts have impacted the work we can provide to our communities. For example, a tri-county program called the Center for Clean Start was for mothers who had substance abuse problems and provided critical care for the individual and the child. For more than a decade, our local health department operated this program and served residents in 3 tri-counties, Worcester County, Wycomico County, and Somerset. Due to funding cuts, this service was removed from our local health department and is now operated in a private entity. The child care services that were provided by our local health department to the mothers who were participating in this program ended because we didn't have the staff to continue the program. Ultimately, the program was taken away from our local health department and sent to the private operator. Case management services that we addressed, where we addressed our residents' basic needs and supportive life services, were also cut last year and transitioned to a private operator. These are just 2 examples of problematic services that were cut from our local health department due to funding issues with the local health department. Regarding the Commission on Public Health's report, challenges recruiting and retaining staff were identified. We are losing people because we are not offering a competitive compensation. We agree with the commission that we must increase compensation in order to attract more people in our local health departments and continue to deliver critical public services. We are asking the committee to support increased compensation in order to retain our veteran employees and recruit new employees into state services. Please do not balance this budget on the backs of our dedicated state employees. Thank you so much.
Good afternoon. My name is Jenny Reese, and I'm a licensed practical nurse at Springfield Hospital Center. I'm the proud local president of AFSCME Local 539. Today, I come before you to bring your attention to the issues impacting state employees who work at the Office of the Chief Medical Examiner and highlight why competitive compensation is needed for our state employees in the Maryland Department of Health. At this location, we represent autopsy assistants. They are tasked with receiving the deceased and preparing them for autopsy. They assist through the procedures from opening to closing. They also provide support for grieving families who have had to identify their loved ones' remains, and much more. And their starting salary is just over $40,000 a year. They rely on overtime opportunities to pay their bills. And our employees are doing their jobs to the best of their abilities with the resources that they have. They really could use better instruments for autopsies. They've been using kitchen knives. We need better tables for autopsies. Recently, the tray table fell out during a procedure. We need to make sure that our employees can do their jobs efficiently and safely. And that includes having access to vehicles that are equipped with all-wheel drive or four-wheel drive to be able to go to scenes and transport bodies in inclement weather like the snow we recently had. Our forensic investigators go to active crime scenes and collect forensic evidence that assists the medical examiners in establishing time and cause of death. And their salaries are significantly less than other states' forensic medical investigators. Our challenges must be addressed by compensating our employees with competitive wages that reflects the value of their work. The FY27 budget has proposed a COLA that does not keep up with inflation, and it fails to provide a step increase for state employees. We are asking this committee to support our request of a 2% COLA and a step increase in order to retain our veteran employees and recruit new employees into state service. Thank you.
And thank you. First, I want to just lean in and say just thank you for your service. Thank you for what you do for our state. Word of advice that helps myself and possibly my colleagues. So when we do, the oral testimony is always great, but the written testimony, when you see me rolling through the papers, typically I would ask the agency of what the public testimony from that standpoint to comment on some of the things that they may be hearing. We'll follow back up in reference to it. It sounded like wage compensation as I was listening to what you're saying. But like in the future, if you do come to testify, the written also helps. So that way we could just ask the agency to comment on issues that may be outliers. Thank you again for your service.
Thank you.
Thank you.
And I believe that that is all of the public testimony that we have for the Public Health Administration colleagues. And seeing none, at this time, we're going to move to our last agency. Thank you, Madam Secretary, and thank you again, Ms. Kamara. We're going to move to our last agency, which is the West North Avenue Development Authority. I was going to give it an AKA name, Craig. But then we will bring up Ms. Elizabeth Waybo.
Thank you, Mr. Chair. I'll be presenting the budget analysis for the West North Avenue Development Authority, or WNADA, which is an economic development agency focused on a section of West North Avenue in Baltimore City. WNADA's fiscal 2027 budget decreases overall by about $2.7 million, or 12%. $1.2 million of that decrease is due to a fiscal 2026 deficiency appropriation to restore funds that were reverted in error at the end of fiscal 2025. On page 2 of the analysis is a breakdown of changes made to the fiscal 2026 budget since last year's budget hearings. And some of those are due to legislation last year that officially made WNADA an economic development agency and established a special fund. The legislation also gave the agency some new authorities and required it to be self-sustaining by fiscal 2028. The 2026 budget as enacted appropriated $19 million for WNADA's grant program in fiscal 2026. And as you can see in Exhibit 1, the WNADA board has reallocated $10 million of that to establish a new loan program. And they've also reallocated about $1.6 million from grants to operational costs, primarily for contracts. Reallocating grant funds to cover operational costs has been a recurring issue for WNADA, and this is discussed on pages 5 and 6 of the analysis. The agency's budget is under a single program, which allows the agency to reallocate funds to various purposes throughout the year without having to file a budget amendment. And contract costs in particular have been much higher than what is programmed in the budget books. Exhibit 4 shows that contract costs in the budget books have always been programmed below $200,000, including in the fiscal 2027 allowance. However, the actual spending has never been less than $300,000. In fiscal 2025 and in the fiscal 26 budget adopted by the board, contract costs are over $1 million annually. So even though the fiscal budget books show $174,000 for contract costs, they're probably going to be actually more like $1.8 million, $1.8 million, which means that less will be available for grants. So DLS has asked WNODA to comment on major areas of contract expenses in fiscal 2026 and whether the agency expects those contracts to continue to be needed in 2027. And DLS also recommends that the committees adopt narrative requesting that WNODA and DBM work together to program more realistic budgets in the future that minimize the need to reallocate funding away from grants. The personnel section starts on page 6. WNODA has 15 regular positions, and of those 6 positions, or 40% of them, are vacant. WNODA reports that these were affected by the hiring freeze, which was lifted in October, but they have had difficulty attracting and retaining staff. While some factors are out of the agency's control, such as the hiring freeze and the agency's sunset clause, there are some other things that the agency may be able to address, such as requiring in-person work and long hours. So DLS has asked WNODA to comment on its effort to fill those vacant positions. On page 7, there's an update on WNODA's grant program, which makes up the bulk of its funding. In fiscal 2025, the agency awarded 33 grants totaling about $13 million. And Exhibit 5 shows the different categories of grant funding. Just over half of the grants, the grant funding was for economic development projects, and 28% was for housing. Exhibit 6 shows some of the managing results metrics for WNODA's first 2 years as a state agency. These track the number of developers or families supported and the amount of grant support that the agency awarded. And DLS has asked WNODA to comment on the feasibility of adding some broader outcome metrics to the MFR, such as vacancy rates and the population in the target area. If those are something that WNODA is able to track on an annual basis and add to the MFR reporting, it could be a good way to gauge the agency's overall effectiveness. Page 9 of the analysis summarizes legislative changes that were made to WNODA last year. The legislation gave the agency new powers and tools and also required it to be self-sustaining by fiscal 2028. That requirement is one of the reasons for establishing a loan program, and DLS has asked WNODA to provide an update on its plans to offer loans. The legislation also set a sunset date in the first quarter of 2023, which doesn't give the agency much time to ramp up its operations and become self-sustaining and then either terminate or reincorporate as a non-state entity. WNODA is required to report on its progress toward becoming self-sustaining by January 1st, 2027. And you'll see the DLS recommendation on page 10. That concludes my presentation.
Senator Oxley, no, man, you learning.
I'm still trying to learn. I'm back on this person. No, this is not with them. It's just more generally. They have 14 actual, 15 working with an allowance of 15, but then we're showing 6 vacancies. How do those things interplay? I don't understand.
Yeah, so in fiscal 2025, they had 14 regular positions and then 1 contractual position. So now in fiscal 26 and 27, they just have 15 regular positions, but 6 of them are currently vacant.
So they're budgeted for 15, but there are 9 in reality.
Correct.
Is that what it is?
Yeah.
And then when I look at the budget sheet, the actual is the 1.7. Working was the 2. I'm talking about the salaries and stuff that would relate to the numbers, right? Mm-hmm. The 1 point, they had the 15, so that's the 14. The 2.1 is the working, assumed the hiring more people that didn't actually happen, or couldn't happen, rather. But now we have a bigger number here because there's an expectation that they are going to be able to hire? Like, I'm not understanding.
I mean, I think the hope is that they will be able to hire. Their budget right now, yeah, I mean, the hope is that they would be able to hire these positions. I wouldn't look so much at that last page just because that budget that we get from DBM is different from the working budget that the board is looking at. But yes, that's maybe something the agency could speak to, like whether they expect their personnel costs to actually come in that high if they have so many vacancies.
Okay, and again, I'm trying to get there. So you're saying I shouldn't necessarily look at this, but this is what I have to look at.
I know, yeah, that's kind of an issue with the agency's budget overall this year is that, what we've got in the budget books, which is what you see reproduced on the last page there, isn't necessarily like what they're actually looking at internally. So I would expect, so if you look at page 2, that's the, that column working budget there, that's what the.
Page 2 where?
Page 2 and Exhibit 1, that column working budget, that's what the board is actually working from for fiscal 2026. And I'm not really sure how close that will be to fiscal 2027. I would expect it to be similar, but maybe that's something the agency could speak to of what they expect their actual personnel costs to be given the vacancies and what they're looking at in terms of actually spending on hiring.
But the bigger question though that you posed for understanding is the disconnect. It's not I'm not saying not about this. Like it's the disconnect between DBM and the working budgets kind of across the board. Like that's not necessarily them, is what you're saying.
Yeah, I'm not sure
I'm
where.
not trying to disrespect you.
Yeah, I'm not sure where the breakdown is, but there is like a difference between what we're seeing in the budget books that we reproduce on the last page there and what like the actual expenses are that Wanata's is running into. And it's, it's all budgeted under one budget code, so they are allowed to reorganize as they need during the year, but we would expect, and that's, why we're recommending adopting some language, we would expect what we get from DBM we would expect for them to work with Wanata and give us something that is more realistic and closer to what they're actually expecting to spend.
I appreciate the indulgence. Thank you.
Yeah. And I'm gonna give you one of my secrets. So typically these analyses come out in a couple days. In my first 3 years on this committee, they would come to my office and I would have all my questions to do a pre-meet to be able to get, because like you said, just learning and it's a lot, you know what I mean? So like they'll come through if you mark it up with any type of questions, that way you can get it done.
Yeah, we're happy to meet also if you like.
Yeah. At this time, we're gonna call up, I was about to say my guy Chad, but we're gonna call up Mr. Director Williams. Director Williams. And I need you to lean in on Senator Augustine's questions too, please.
I'm looking forward to that robust discussion. Good afternoon, Mr. Chairman and Senators. It's good to see y'all always. For the record, Chad Williams, Executive Director of the West North Avenue Development Authority. And this year, I brought up recently promoted senior analyst at the West North Avenue Development Authority, Christy Turner, who started with our agency as a graduate from Coppin and as an intern. So she's been with us since the start. So I did, as always, provide a very detailed written testimony, but I do want to highlight some things over the next few minutes. I can probably do that in 2.5 minutes. As you know, the West North Avenue Development Authority was established to create a revitalization plan that would help thrive businesses and residents in the West North Avenue corridor from the 600 to 3200 block. With the approval of SB 4 and HB 258 last year, now the authority is able to move toward being self-sufficient as it can operate as a private entity, create a special benefit zone, charge and collect fees, but also own, dispose, and sell property. On January 25th, the authority submitted a comprehensive plan to the General Assembly. And one of the things that we have done recently past year is that now we have incorporated additional development activities such as arts and culture, neighborhood development, and health, welfare, and public safety to combine those with housing, economic, transportation, and green space development. This current fiscal year, our agency has taken those various development plans and we've now created those. There's a hyperlink where you see future of West North Avenue. If you go to that hyperlink, you'll see all of the conceptual renderings that we envision for West North Avenue being developed over the next 15 years. One of the things that was asked by the chairman last year and over the past couple of years, not only from DBM but DLS, was an economic impact analysis. What we've done is we've actually contracted with the University of Baltimore to produce that economic analysis. Mr. Chairman, we did reach out to Coppin, Morgan. We're still working with Morgan on our transportation analysis, but the University of Baltimore provided the best pathway for us to provide this analysis. In that analysis, it was determined that over the 15 years, based on WNODA's redevelopment plan, that of 290,000, that would support $473 million in Maryland economic development activity. And that would generate also, Mr. Chairman, you asked on hard numbers, to actually acquiring 450 vacant and blighted homes over the next 15 years, and also producing 750 multifamily units. In WNODA's investment, we try to average our investment somewhere around 31%. That will generate 69% in private activity. We try to invest no more than 40% of total development costs. As far as performance, since FY24, our housing development activities have acquired 70 vacant and blighted residential properties. 16 are now complete. 54 are currently under construction, and we are in the process of acquiring 30 more homes, but particularly between the 27 and 2900 block of West North Avenue, which is a very 3-block blighted and area along the corridor. That represents about 100 homes that we've done in just less than 2.5 fiscal years. Our economic development activities, we have acquired 6.8 acres of vacant and abandoned land, one of those big properties. If you're familiar with Baltimore City, is the Greenwood Towing site, and West North Avenue is one of the largest sites in the city that's vacant, 2.5 acres, and then 1.5 acres at the 600 block of West North Avenue in partnership with Blank Slate Development and MCB Real Estate to bring a streets market grocery store to address the food desert along West North Avenue. As far as transportation, we have partnered with the Graham Project and Open Works to improve pedestrian safety at the intersections of West North Avenue and McCullough and Druid Hill, and our bullet point what those transportation and public safety improvements are. As far as neighborhood development and engaging folks to come to West North Avenue, we are now partnering with Delegate Wallach and Senator Hayes and the establishment of the West North Avenue Neighborhood Social Connection Development Act, which has been dropped this week. And one of the things that we want to look at is how do we invest in social connectivity through our neighborhood associations, community development agencies, open green space, and arts and culture and festivals. And that will hopefully generate more people to be interested. Through our arts and culture activities, we have done activation activities at the Mill on North, which we invested in, which is a food hall on West North Avenue in partnership with Coppin Heights CDC. And on average, I would say that that food hall generates about $27,000 on the weekends for economic development. We've also moved forward and robustly in public safety. As you know, the Penn North Corridor is a very challenging area for many social challenges, and so we've partnered with Frontline to address cleanliness and maintenance, resident resources, and crime prevention through environmental design. And actually, our public safety team actually won the national award in crime prevention and environmental design from the Institute this past year. We have achieved a 55.5% MBE goal rating last fiscal year. And then in response to DLS's questions, our particular large expenses on contracts have primarily been due to our urban planning and architectural conceptual designs. Those contracts have ranged on an annual basis between $250,000 and $350,000. We do see those falling off as we now go into implementing those plans and joint ventures and development. However, as we continue to acquire property, we're going to be addressing building security. We also have our own building that we'll be moving into later this year. So those costs, we have to see how those fluctuate. but to answer your question, that's the bulk of our contractual expenses. We do agree, and we'll get to that, Senator, we do agree that DBM should work with us as we do put in realistic conservative budgets, and we can discuss how do we get there in that divergence. We do agree that we would like for DBM to put in more data that we collect, and it's something that we've pushed for the past 2 years that Christy reminded me after our testimony in the House on collecting housing, residential, commercial properties that we develop or fund for development, and then also how we're increasing population, sales, and property taxes. This is information that we have asked for that DBM put into our MFR, so we would definitely appreciate that coming from the General Assembly. And then last thing is that the board is prepared to review and discuss, hopefully discuss and approve our loan manual. I did put a hyperlink so you can see the draft of our loan manual, and they're looking to do that on March 30th, and hopefully we will start loans on April 1st. So I look forward to answering. I know the chair will probably ask me questions about vacancies. You're going to ask me questions about the budget, so I'm prepared. Thank you.
Man, I ain't got no questions about no vacancies. I do have a question in reference to, you're right, I was thinking about the vacancies.
Yeah.
Can you connect back with Ms. Waybell in reference to the timeline of some of the vacant positions that you said you was going to do after the hiring freeze in October? I know that in the testimony it spoke to just obviously to hold the freeze, but then having a challenge. We're in February, so just if you could just send back what some of the goals that you have in reference to the hiring, that would be helpful.
Yeah, I'll definitely provide you a robust timeline. What I will say on the record that although there is a hiring freeze, there was some, I would just say, there was clarification from DBM to all agencies. The agency heads could unfreeze those positions, and then that became very convoluted and didn't really get worked out until November. But I definitely will give you the timeline and how it affected our agency, and that might be used as a reference for you.
Yes, sir. Okay. Seeing no further questions, colleagues, and there is no public testimony for this respective agency. Just want to say congratulations. My wife's a Coppin alum, so and we just met with Dr. Jenkins, so congratulations, and you're working with a phenomenal agency. Senator Hayes will be happy. Just want to say, colleagues, I look forward to seeing you, I believe, Friday, tomorrow, for our next, the day is. It is Thursday. It is Thursday. Yep, me too. But I look forward to seeing everybody Friday. Y'all have a blessed day.